Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on sexual health organized by TNFOG. So it's my privilege to introduce the moderators of today's webinar, Dr. Gayatri Ma. Ma'am is the executive member.
Radhika introduced, I think Gayatri is not there. You introduced Dr. Radhika.
Will come later, ma'am.
The other MOC is Radhika Gauri ma'am. Ma'am is specialist consultant in OBG and clinical lead ESIC Hospital, Tirunelveli. I welcome you, ma'am.
Thank you. Thank you, Sahiti. I thank the TNFOG President Secretary, ma'am, for giving me this opportunity, and we will start the CME with the prayer song. Tamil Thai வாழ்த்து.
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
I welcome Dr. Sampath ma'am, who is our TNFOG secretary, and we all know her. I welcome her to introduce Dr. Vidya ma'am. Dr. Sampath ma'am is our professor HOD.
No, Radhika, no problem.
Yes, ma'am.
Thank you, Radhika.
Yes. Thank you, ma'am.
Yes. Good evening to all, and I welcome you all, Dr. Seshasai, Dr. Krishna Kumari madam, and all the faculties and delegates and MOC and president for this TNFOG Marathon CME. This is a CME, Marathon CME we are conducting for more than 3 years. Here we have 3 sessions. First session being the Yuva session. The theme will be a single topic. Today we have the sexual health. The 2 Yuva will be giving the talk, and in the annual conference, Best Yuva will be awarded. This is conducted on second Friday of every month. Second session is the update on that particular. Today we have the vulvoplasty and vaginoplasty by Dr. Deepa Ganesh. And third, we have the panel that is moderated by seniors, and we have the juniors as the panelists. This is our Marathon CME continuously going on every month. This month, since tomorrow is Valentine's Day, we thought we can have sexual health as our theme. Now I welcome our President, Dr. Vidya Prabhakar Madam, to give the welcome address and introduce the chief guest and guest of honor. Dr. Vidya Prabhakar is President of TNFOG, past President of Salem Society OG, and Assistant Professor from Manipal. Yes. Welcome, Madam. Madam's interest is high risk pregnancy, PPH, and infertility. Welcome, Madam.
Thank you, ma'am. So I'm extremely happy to be part of this marathon CME. So as the name itself suggests, it's been running like a marathon. Like it's been going on and on and on for the last 3 years without any break. Every month on the second Friday, and every month we've had UAs participating. And at the end of the year, we are judging and the same judges, like they have been there throughout the year and they judge the US. Every time they only give the marks so that there is uniformity in that. And at the end of it, they get the prizes too. So I think it is a brilliant effort by Dr. Sampath Kumari ma'am. And it's been going on. I think it is time for me to introduce our chief guest, Dr. Sesha Sai sir. Can we have his CV, please? So Dr. Sesha Sai sir is president of OG Society of Chittur. So we have today the Andhra people. And sir, we welcome you. Can I see him? I'm not able to see him. He's there. He's logged in. Dr. Sesha Sai sir is here.
Yes, madam.
Oh,
Vidya
yeah.
madam, one
Welcome,
point.
sir.
He has given a simple CV as president. Before COVID itself, he was the one who did that PG classes in the Zoom. Yes, sir. Sir is in the flight, I think. Yes, sir. Sesha Sai, sir.
Yes, ma'am. Good evening, ma'am.
Yeah, good
I'm
evening,
very
sir.
happy to see all of you on Valentine's Day.
And it's a very apt subject, as Sampath ma'am has said. And we are very happy to have you indeed, sir. And so we would like to hear a few words from you and blessings for the program and wishes. Over to you, sir.
Good evening, ma'am. I'm very happy to see all of you. And it is one of the best teaching programs we observe. And I know Dr. Sampath Kumari, madam, and you, for the past 4 decades, I'm observing you. And one of the best institutes from the Chennai, I used to love to see always as examiner or field speaker. So one of the best programs also you are organizing, the health aspects today. And I feel it is one of the most important for the postgraduates and the faculty to hear and to practice and to help the society. And I think it is the best way to approach. And today is the most precious day to hear such a good voices and good programs. And I hope always this type in TNFMD will do. And it is the best learning object for this to see in examiners group. Many people they used to ask, and we used to give programs and latest objects we used to give. And these are the programs where we are seeing the applications and rebounding the results. I thank for giving this chance, ma'am. Thank you very much. And all the best for this program. And
Thank
all
you
the
very
best
much,
for
sir,
all
for your
factors.
blessings. Yeah.
Thank you,
Thank
ma'am.
you very much, sir. We are indeed proud to have you here on the program. I think till your flight takes off, or is it landed? Taking off, sir? I hope we'll have you with us.
Yes, sir.
Thank you, sir.
He is
Thank you,
sharing a lot of the informations in this examiners in OG group, WhatsApp group. Very useful for the practitioners and as well
Thank
as
you, ma'am.
Thank you very much indeed, sir.
Thank you very much. Thank you, ma'am.
Thank you, Sesha Sai, sir.
Yeah.
Vidya
Thank
madam,
you,
you can introduce Dr. Krishna Kumari madam.
Yeah. So it gives me great pleasure to introduce our guest of honor, Dr. Krishna Kumari ma'am from Hyderabad. Oh, wow. So she is the HM Lazarus Gold Medal. She is the one indeed in MD, and she is Professor Apollo MSR Hyderabad, Senior Consultant Medicover Women and Child Hospitals, National Corresponding Editor Jogi. My God, she's got a lot of awards and a lot of important posts that she has had. And so,
Thank you,
yes,
Dr. Vidya. I think it's a pleasure being introduced by you. Thank you so
madam. And of course, you've contributed to Foxy Focus as well. So I would like to mention that as well. You've got a lot of publications. Anyway, thank you very much. We are indeed proud to have you
Yes,
here,
sir.
ma'am.
Thank
Currently
you,
for
Dr.
HBT
Vidya.
also she was one of the contributor.
Yeah.
Yes, madam.
Yeah, with Sampath, we have done this fever, and fever in pregnancy was one of her Foxy Focus I've done with her.
Yes.
Our
Very nice.
education goes a long way from the time she was in the beginning in the adolescent committee. From
Mhm.
then, we know each other very closely. So it's a pleasure meeting you, Dr. Vidya, and the whole team of TNFOG. Of course, Sampath, I don't have to say. It's always a pleasure seeing her. Thank you,
Yeah.
all of you, for
Very nice
inviting
to,
me.
yeah, very nice having you here with us, ma'am. I just had a doubt. Did you come to Salem also for the last Yuva Foxy?
No, 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 I could not come because I
Mhm.
was I had some other
Yeah,
program.
but your name was there, isn't
Yeah,
it? Because
I
I
think
remember
last
I was
minute I could
thinking I
not.
didn't meet you.
Yes,
Okay.
right. So
Okay.
thank you all for
Thank
inviting
you.
me today. And like I've seen, I have the whole team, TFNOJ is always active in its or academic activities. And the name suggests, marathon is really, I'm sure it is going in a great way. And I'm waiting for the marathon goal, the winner of the marathon. When I don't know when, one more year before you, will it go on and on and on forever? I
No,
think.
ma'am, the annual conference will be in June, so by then it will be decided.
Oh, good, good, good. So it's a pleasure to know the winners of the marathon race. And of course, sexual health is such a very, very important topic. I'm so glad that you have chosen it. It is something which is always going undetected because we are not talking about it, we are not asking about it, and the patients are not volunteering information about it. So it goes unaddressed most of the time. So I'm so glad that you have brought in this very important topic into the limelight. And I think we have to make it a policy that we just have to ask every patient as a routine. Many a times when we are talking about hysterectomies, vaginal surgeries, whenever I do, suddenly I realize, did I ever talk to the patient about what is her need? Who am I to decide? She's 60 or 70 or 80, and then say no, let's do a call crisis. It's not we who decide it. We should. Uh, it's a patient who decides, and the patient doesn't decide until, I mean, they don't volunteer until we ask them. So I think my take home message for the youth is ask. Just ask. We ask, they answer. That is the how we get into it. And of course, we all know about the abuse also. So these two things, I think, have to be a part of our regular OPD care. I think with this, I would like to wish the TNFOG a great going, a great race. And of course, I would like to especially wish Sampath on having everything, have our wishes to come true. And my best wishes are always with her. For whatever she wants to achieve in her career, my wishes are always with her. Thank you all once again and have a great reading and a great learning. Thank you.
Thank you, Dr. Krishna Kumari, for joining us and wishes. Thank you. Thank you so much.
My
Thank
pleasure.
you, ma'am. Mm.
A word,
Okay,
Dr.
ma'am.
Sesha Sai, yes, I know. I met him as an examiner, and like Dr. Revati was saying, he's a great teacher of. I mean, he helps us in a great way with all his academic contributions to, especially to PG teaching. Thank you, Dr. Sesha Sai. Nice meeting you on
Thank you,
the
ma'am.
platform.
Thank you, ma'am.
Thank you.
It's so nice to have two people who are really interested in academics and PG teaching. Really, we are blessed to have you all here. Thank you very much, Sesha Sai sir and Krishna Kumari ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
So with
So,
that, I hand over the proceedings to Dr. Radhika Gauri.
thank you, ma'am.
Yeah.
Thank you so much, ma'am, for the nice introduction of our chief guest. And thank you, Seshtai sir and Krishna Kumari ma'am for wonderful advice and you all of us. And we request our judges, Dr. Shanti ma'am and Dr. Kartika Prabhu ma'am, to take over the session. I invite Dr. Shanti. Can you please put her CV? Yes, display her CV, please.
These are all the two judges, Krishna Kumari madam. They are doing for the past 1.5 years.
Yeah. That's what I've heard you all say. And when you are addressing them, that I mean, Dr. Vidya, I think, said that the same
Vidya
judges
ma'am.
are there from
Yes.
the beginning, so that there's uniformity. This is one thing which I always say. I feel sad when there always the students complain that I mean, some examiners give more marks, some don't give. So there is a difference whenever there is a judging. So I'm so glad that the same people have taken it for such a long time and are going ahead. Congratulations,
Yes.
Dr. Shanti and Dr. Who's
Kartika
Kartika
Prabhu.
Prabhu.
pardon?
Kartika.
Kartika. Yeah, wonderful names. And I'm so proud of you all that you are taking it completely so seriously, that you are doing it for such a long time. Hats off to you. And keep the good work going.
In spite of that, I don't tell them the theme only 2 days back. They will see from the invitation. Take it for granted. So thanks to Dr. Shanti and Dr. Kartika. Yes, Radhika, proceeding.
Yes, ma'am.
Thank you.
So Dr. Shanti is a professor, Department of Gynae in Savita Medical College and Hospital in Chennai, Tamil Nadu, and she has done her MBBS from Madras Medical College and also MDOG from Institute of Obs and Gynae, the prestigious institute from Madras Medical College. And she's trained in ultrasound and advanced infertility, advanced laparoscopy. She's also a provider of advanced life support in obstetrics. And she has more than 25 publications. And her field of interest is endoscopy, high-risk pregnancies, adolescent gynecology. And she has numerous achievements, and she's also an examiner for UGs and PGs and invited faculty in conferences, and she's organized many conferences. And I invite the other judge, who is Dr. Kartika Prabhu, who is also a professor from SRM Medical College Hospital and Research Center, Katanglatur, and she has done her MBBS from MMC and MD from JIPMER, and she is also an undergraduate, postgraduate teacher, and her special interests are in high-risk pregnancy, gynae endoscopy, and midlife health. And she has won numerous awards. Dr. A.V. Umaguchi Memorial Gold Medal. And she of the Dr. A.
Kartika Prabhu, she has many awards. Dr. Asha Bakshi
Yes,
Award,
ma'am.
Annual Conference, AACC, RCOG 2016, and Best Paper Presentation, UOFOXY 2011, DIPSI 2013, Gold Medal Research Day on SRM 2020, Yale Mudalia Traveling Fellowship, faculty in many national and regional conferences. Welcome. I invited Dr. Shanti and Kartika to introduce the speakers.
Good evening, madam. Thank you for the opportunity. And so moving on to the session, the first speaker, Dr. Vijitra, who is a consultant at NHCA Singapore. And she has completed her MBBS in Madurai Medical College and MS in SRMC Chennai. And consultant at Vijay Hospital Karur at present. And she's the secretary of FOGSI Karur as well. And we are here to listen to Dr. Vijitra about menstrual health. So, which is one of the important topics, and which is not just considered as just a hygiene aspect, but it is considered to be the right of women. So that is the reason why we have all these policies being framed nowadays. Okay, over to Dr. Vijitra.
Good evening, ma'am. Shall I share my screen?
Yes, please.
Shanti, I had told them to talk about menstrual cycle, menstrual hygiene, dysmenorrhea, and basic things.
Yes, madam.
Yes, ma, your screen is seen. You
Yes,
can
ma'am.
start.
Yes, ma'am. I'll start with the normal things, ma'am. So menstrual cycle is a process by which ovary produces and releases ovum. It is signaled by uterine bleeding. Normal menstrual cycle has average duration between 24 to 38 days with a mean of 28 days. It is regulated by HPO axis. As we all know, HPO axis consists of hypothalamus, pituitary, and ovary. GnRH is produced from the hypothalamus in a pulsatile fashion. When based on that, pituitary releases either FSH or LH. If the frequency of GnRH is more, if it is very frequent, FSH will be released, and if it is less frequent, LH will be released. And FSH and LH act on the ovaries and produce estrogen and progesterone, which in turn act as a feedback mechanism. They act on both ovaries and hypothalamus, and it is regulated. So based on a 28-day cycle, we divided into two phases. The divided into follicular phase and luteal phase based on the happenings in the ovary. Follicular phase from day 1 to 13, it begins on day 1 of the menstrual cycle. FSH from the pituitary stimulates ovarian follicles to grow, which secrete estrogen, which produces proliferative changes in the endometrium, and this is called as proliferative phase. Ovulation happens on day 14, where there is because of the high estrogen, there is a surge in the luteinizing hormone from the pituitary, causing ovulation into the fallopian tube. So luteal phase begins on day 15. The follicle becomes the corpus luteum, producing high levels of progesterone and some estrogen, which produces thickening of the endometrium, which to become a receptive potential place for implantation. This is called secretory phase based on the endometrial change. Then if the fertilization implantation does not happen, the corpus luteum deteriorates. So there's a sharp fall in the progesterone and estrogen level. This gives a feedback mechanism and causes the endometrium, the loss of hormone support causes the endometrium to shed, resulting in menstrual bleeding. This is a normal menstrual cycle, which is illustrated here. FIGO has classified what are the normal parameters of menstrual cycle. Frequency of anything between 24 to 38 days is normal. Less than 24 is frequent. We call it as polymenorrhea, and more than 38 is infrequent, naming it as oligomenorrhea. Duration up to 8 days is normal. More than 8 days is not okay. Regularity, a variation in a particular person's cycle may vary between 7 to 9 days. More than this, we call it as irregular. And volume is a completely subjective assessment. It is when the bleeding is heavy and the patients feel it impacts the quality of life, then we call it as heavy menstrual bleeding. This is depicted in a table. So we'll just, the more common problems we face is menorrhagia and dysmenorrhea. So menorrhagia, more common causes of menorrhagia are hormonal imbalance, which we see in PCOS, obesity, and thyroid issue. Then uterine abnormalities like fibroid, polyps, adenomyosis, bleeding disorders, inherited such as von Willebrand disease. Intrauterine devices, copper-based non-hormonal IUDs can cause increased bleeding. Pregnancy complications like miscarriage or ectopic pregnancy, medications, anticoagulants, and any kind of malignancy, uterine, cervical, or ovarian cancers. Other conditions like PID or liver or kidney disease can also cause menorrhagia. PIGO has classified this as structural and non-structural causes, naming it as POM coin classification. POM includes polyp, A for adenomyosis, leiomyoma, uterine fibroid, and malignancy, M for malignancy and hyperplasia. Non-structural causes like coagulopathy, ovarian dysfunction, E for endometrial causes, I for iatrogenic, and N for otherwise classified. Example, Sisson's scar defect, uterine niche can cause AUB. Figure 2, this is a classification for fibroid. Figure 2 classification. Based on the location of fibroid, it is classified as submucosal, intramural, subserosal. Hybrid myomas can be like in 2 or more places. I mean, it can be from submucosal till subserosal. So based on the location, Figure is classified fibroid. The other most common problem we see in OPD is dysmenorrhea. Dysmenorrhea is primarily caused by excessive level of prostaglandin, which triggers strong uterine contraction. This reduces oxygen supply to the uterine muscle, causing pain. It is categorized into primary and secondary. Primary has no underlying condition and can be very well treated with NSAIDs. Secondary has some structural causes leading to dysmenorrhea, which needs to be addressed. Other factors like smoking, stress can also trigger dysmenorrhea. So more common causes are, as we know, endometriosis, adenomyosis, fibroid, PID, cervical stenosis, structural abnormalities in the reproductive system like imperforate hymen can cause cyclical pain. Then IUDs, particularly copper-based devices, can cause cramping. So we just see more about adolescent menstrual health. As per ACOG, adolescent normal menstrual cycles in adolescent girls are as follows. They attain menarche at a median age of 12.4 years, and the menstrual cycle in adolescence is typically between 21 to 45 days, mean being 32 days. The flow should be 7 days or less, and they should not use more than 6 pads or tampons per day. An evaluation of primary menarche should be considered for any adolescent who has not reached menarche by the age of 15 years or has not done so within 3 years of telarchy. AUB in adolescent girls. Although long interval between cycles is common in adolescents due to anovulation, because the HPO axis takes time to get matured. The immaturity of HPO axis can cause anovulation. It is statistically uncommon for girls and adolescents to remain amenorrheic for more than 3 months. Anything more than 3 months needs evaluation. They should menstruate at least 4 times in a year. Menstrual flow requiring change of menstrual products every 1 to 2 hours is considered excessive, particularly when the flow lasts more than 7 days at a time. More common causes in adolescent girls is immaturity of hypothalamic pituitary ovarian axis. It can even take up to 3 or 4 years from the menarche to get matured and proper cycles to happen. Then other common causes, hyperandrogenic ovulation conditions like PCOD, which is very common in adolescent age group. Other causes like congenital hyperplasia and androgen producing tumors. Other common causes, coagulopathy, like von Willebrand disease, platelet function disorders, and other bleeding disorders. Hypothalamic dysfunctions like eating disorders leading to obesity, underweight, or significant weight loss, or stress-related hypothalamic dysfunction can cause AUB. Hyperprolactinemia, thyroid disease, primary pituitary disease, primary ovarian insufficiency, or malignancies like estrogen producing tumors can be common in that age. And any other uterine lesions should also be considered, and pregnancy should also be ruled out. Coming to adolescents, we have to teach them menstrual hygienic practices. Like to wash hands before and after using a menstrual product, to discard the menstrual products properly, like to wrap them up and not to flush them in the toilet. We should educate them to change the sanitary pads every few hours, even though there is no very light flow or there is no flow at all, and more frequently if the flow is heavy. And tampon should be changed every 4 to 8 hours. It's better to use a low absorbent tampon and change very frequently rather than using a high absorbent tampon and keeping them for long hours. Menstrual cup is changing the game. Clean cups can be used, and we have to educate them to sanitize the cup, wash the cup after every use, and to sanitize the cup after every cycle. Then clean underwear can be used. So we have to teach them to use comfortable, lightweight clothing such as cotton underwear. Tight fabrics can cause germs to grow. Not changing the menstrual pads or tampons can cause the growth of bacteria and fungi. We have to educate them to keep the genital area clean and use only water to rinse the vulva. Vagina is a self-cleansing organ, so using harmful chemicals can change the pH of the vagina and can trigger vaginal infection. Better to use unscented toilet paper, tampons, and pads, because scented hygienes can irritate the skin and impact the natural pH balance. We have to tell them to drink enough liquids so that they don't get urinary tract infections and other infections like yeast infections. So how to overcome the challenges in that age? Just only by education. We have to provide enough knowledge about menstruation before menarche to reduce fear and stigma. We have to ensure they have access to all the facilities at schools and public places, access to supplies and support system from the parents, teachers, and health workers. As per the recent study, all over India, more than 95% of adolescent girls in India are using hygienic methods in these 4 states of Tamil Nadu, Goa, and Delhi, Telangana. They are well educated and they practice hygienic methods. Thank you.
Good presentation, Vichitra.
Thank
So you have covered the basics of menstruation. So one correction I want to make, you mentioned about polymenorrhea and oligomenorrhea. These terminologies have been left, so it has been modified, right? According to Figo's classification, we call it as frequent and infrequent cycle rather than oligomenorrhea and polymenorrhea.
Yes, ma'am.
Okay. So you mentioned about adolescent health, how we are going to improve the adolescent menstrual health. So can you tell some lifestyle changes which we can make to improve the menstrual health?
So since PCOD is becoming more common at this age group, we have to, from very young age, we have to educate them about the lifestyle modifications, like to eat healthy, not to eat junk food, to minimize the usage of plastics, and few things, to be physically active. This can reduce the incidence of PCOD, ma'am.
Okay.
And they have to, sometimes I mean, even if they don't get period for 2 or 3 months, they do not worry. They just get panicked even if they don't get cycle for 1 month, and we can educate them regularly. And pregnancy, that education needs to be given at the adolescent age group.
So,
Actually,
So in addition to that, diet
Yes.
modification,
Ma'am?
stress management also
Yes.
should be done, because stress also will cause an ovulation, right?
Yes.
And there could be a few words about premenstrual syndrome, right? So that also is included in menstrual health. So in menstrual health encompasses both mental, physical, and social well-being. So based on that also has to be addressed, right? Okay. There could be some talk about the toxins that are found in the menstrual products, right? So hygienic products. So can you mention some of the toxins that are being and that is under research
Dioxin,
that are carcinogenic? Yeah.
dioxin, we have now dioxin-free anion pads which are available in the market. And we can very well switch over to menstrual cups, I think.
So each and every product has its own pros and cons. So
Yes.
that also can be highlighted, and the safe disposal of the products. So that also could be addressed. Okay. Thank you so much.
Thank you. Thank you.
Next, we have with us Dr. Ashika Jobson. She's going to give a talk on ovulation update. She's a consultant from Shenbagam Nursing Home, Pattukottai. She did her MBBS from Tanjavur Medical College and MD from Raja Muttaya Medical College. She has done ICOG course in reproductive medicine. She's a life member of FOXI, IFS, PCO Society, and ISR. She is a faculty at various state and national conferences, and she has contributed to various book chapters. Her field of interest is reproductive medicine and high-risk obstetrics. Over to you, Ashika.
Yes, ma'am. I'll share my screen.
Ashika, your presentation is for 12 minutes and they will ask question for 3 minutes, okay?
Okay, ma'am. Yes, ma'am.
Okay.
Is my screen visible, ma'am?
Talk about ovulation and ovulation induction drugs, Kartika and Shanti, in normal and PCOS, okay?
Ma'am, is my screen visible, ma'am?
It's visible.
Yes, ma'am. I'll start.
Start.
A very good evening, everyone. My topic for today is ovulation update. So why ovulation matters in clinical practice? We all know that ovulation is a natural physiological process, and we have been reading the physiology since our undergraduate days. But this session is mainly to focus on the ovulation updates in terms of the newer diagnostic tools, newer drugs and ovulation protocols, newer triggers, and the recent guidelines. So the agenda of today's talk is going to be introduction, physiology of ovulation, its clinical relevance, and updates. Ovulation is the process by which a mature oocyte is released from the dominant ovarian follicle into the fallopian tube following mid-cycle LH surge, making conception possible. For this ovulation to happen, it has to evolve through two processes, the oogenesis and the folliculogenesis, which are two different processes, but they are biologically linked. Oogenesis begins at prenatal life as early as 4 weeks. The primordial germ cells reach the gonads by 7 weeks. They undergo rapid mitosis and multiplication until 28 weeks, reaching a maximum of 6 to 7 million oocytes. And we should understand that oogonal atresia happens simultaneously, reaching a maximum by 20 weeks. So a female at birth has 1 to 2 million oocytes, and by puberty it declines to 3 to 5 lakhs, and by menopause it becomes less than 1,000. So this shows that age is one of the most important prognostic factor for fertility. So coming to oogenesis, by the onset of meiosis, the primary oocyte is arrested in the prophase 1 of meiosis, and this resting phase is called the germinal vesicle. This primary oocyte is within the primordial follicle, and as the follicle grows and becomes the Greffian follicle, under the influence of LH surge, the meiosis completes, and this forms the secondary oocyte. Folliculogenesis has two phases, the pre-antral or the gonadotrophin independent phase and the antral and gonadotrophin dependent phase. As the name suggests, the antral phase is dependent on FSH and LH as well as certain growth factors for the growth of the follicles. So to quickly go through the folliculogenesis, the primordial follicles, which has a single layer of granulosa cell and the basement membrane, becomes the primary follicle, and the important event taking place here is the formation of gap junctions, which help for the passage of molecules for the metabolism and nutrition of the oocyte. And the primary follicle then becomes the secondary follicle. The important events taking place here are that the granulosa cells becomes multi-layered, and there is formation of the theca interna and externa. There are formation of numerous blood vessels, and the FSH receptors start appearing here. The secondary follicle then becomes the antral follicle. An antral follicle is characterized by a cavity or antrum, which is 2 to 5 millimeter in diameter and can be seen on the ultrasound on day 2 or day 3 of scan. The antral follicle contains both FSH and LH receptors. So to know ovulation, there is a strong coordinated hormonal interplay behind the scene. So we all know that the hypothalamus releases GnRH, and depending upon the frequency and amplitude of GnRH pulses, it acts on pituitary producing LH and FSH, and which acts on the ovary to produce estrogen and progesterone. This estrogen and progesterone exerts a negative effect on the hypothalamus and pituitary, thereby bringing the GnRH and LH FSH levels down. We should also understand the two-cell two-gonadotrophin theory, that the LH acts on the LH receptor on the theca cell, which converts cholesterol to androgens, and this androgen enters the granulosa cell, and upon the action of FSH on the FSH receptor, it induces the aromatase enzyme and converts androgen to estrogen. The role of FSH is implicit in folliculogenesis because it is the key initiator of folliculogenesis. It has various roles like granulosa cell proliferation, aromatase induction, FSH receptor expression, LH receptor expression, and dominant follicle selection. The two main important actions are the granulosa cell proliferation and aromatase induction. Thereby, it increases estrogen, which triggers LH surge. So the role of LH is it acts on the theca cell and stimulates androgen production and thereby supports estrogen production. The LH surge itself triggers ovulation, and it also helps in luteinization. So there are certain newer concepts that we have to understand. The concept of FSH threshold and window. So FSH threshold means the concentration of FSH, which this FSH threshold happens in a normal cycle, where the concentration of FSH has to surpass a certain level to progress the growing follicle into a mature follicle. So keeping this in mind, FSH window is the time period for which this FSH should be maintained at the threshold level, beyond the threshold level, for controlled ovarian stimulation, which is the basis for controlled ovarian stimulation, where we keep the FSH window open by giving exogenous HMG and FSH. Again, there is a newer concept called the multiple follicular waves, where initially we thought for one menstrual cycle, there is only one wave of follicular recruitment. Now they have proven that there are multiple follicular waves, and which has led to newer stimulation protocols like dual stimulation protocol and random start protocols. So coming back to our folliculogenesis, the antral follicle one antral follicle becomes the selection and attains the dominance. This dominance is achieved by the follicle whose granulosa cells are most responsive to the FSH, that is, which has the lowest threshold, becomes the first to secrete estrogen and inhibin. This estrogen inhibin sends negative feedback to the HPA axis and suppresses the pituitary FSH. So FSH becomes insufficient to sustain other follicles and they undergo atresia. So this selected and dominant follicle becomes the Greffian follicle or the pre-ovulatory follicle or the mature follicle. So this is the stage after the completion of first meiotic division but before ovulation. It contains a haploid secondary oocyte which we can see in the image, which is surrounded by a pink layer of zona pellucida and which is surrounded by the yellow layer of cumulus oophorus cells. It is approximately ranges from 16 to 29 mm and grows at a rate of 1 to 4 mm per day. So what causes the LH surge? So upon the action of FSH on the granulosa cells and by the activity of the aromatase enzyme, there is a large amount of estrogen that is being produced, and this rise of estradiol into the range of about 200 to 300 picograms for minimum of 50 hours triggers the LH surge. So once the LH peak, it activates the IP3-DAG pathway. So the maturation promoting factor, which was under inhibitory signals, the inhibition is lost and the meiotic resumption occurs. So the process of release of female gamete from the ovary is ovulation. Ovulation occurs 10 to 12 hours after the LH peak and 24 to 36 hours after estradiol peak. Here I want to emphasize that LH surge is not the only hormone to promote ovulation, but there is a role for FSH surge also, because FSH surge causes the nuclear maturation, cumulus expansion, frees the oocyte and COC. So this is the basis behind using GnRH agonist triggers in IVF, and upon the action of LH and progesterone, they release proteolytic enzymes, the follicle wall swells up, and the degeneration of stigma causes follicle rupture and the evagination of the ovum. So how does this LH surge shut down? It is because of the rise of progesterone and fall of estrogen. The progesterone that is rising sends negative feedback to hypothalamus and shuts down the LH surge. And there is also other methods like LH store exhaustion and gonadotrophin surge attenuating factors which regulates the LH surge. So coming to the clinical relevance of ovulation, let's have a look on the ovulation induction drugs and updates. So here we all know that the common oral ovulogens are the SCRMs and the aromatase inhibitors. I have to emphasize here that letrozole has now become the first-line pharmacological ovulation induction in PCOD, suggested by the ASRM and the PCOD committee. Why? Because it has a higher monofollicular rate, better pregnancy rates than CC, minimal adverse effects, and the endometrial and cervical mucus profile is superior to clomiphene citrate. There are also novel letrozole protocols like the STAT-STEP protocol, where we can give letrozole 2.5 milligram for 5 days starting from day 2. Then we do a scan. If there is no follicle, we can increase the dose by 5 mg. Then repeat the scan. Then if there is no follicle, we can increase the dose by 7.5 till we get a follicle of more than 18 mm. This is called STAT-STEP protocol. The other protocol is the extended protocol, where we give letrozole 2.5 milligram or 5 milligram for continuous 10 days. And if the lead follicle is more than 18 mm, we trigger and plan accordingly. There are also other methods like the step-up protocol, which is very much helpful in PCOD and clomiphene-resistant PCOD. We give letrozole 2.5 milligram on day 2, 5 milligram on day 3, 7.5 on day 4, and 10 milligram on day 5. And once we get the dominant follicle, we trigger and plan accordingly. There is also a single dose protocol, which is very much helpful in unexplained infertility, planning for IUI. So we give a single dose of letrozole of 20 milligram on day 3. And from day 7, we can add up on FSH 50 to 150 international units, depending upon the patient. And then we trigger and we can do the IUI. So clomiphene citrate, though it was earlier the widely used drug, now has become the second line, mainly due to its limitations of thin endometrium, poor cervical mucus, and clomiphene citrate resistance. So how to monitor ovulation? Though we have various methods, transvaginal ultrasound is still the gold standard. And even in transvaginal ultrasound, there are emerging recent updated techniques like applying Doppler flow in ovulation, where we see the follicular flow, the resistant index, and the peak systolic velocity.
You have 2 minutes to go.
Yes, ma'am. So if the follicular flow is more than grade 3 and 4, it is indicative of good dominant follicle, and the resistant index should be 0.4 to 0.48, and the PSV should be more than 10 centimeters. That indicates a strong follicular maturity. So we all know the old ovulation triggers like HCG, which is widely used for timed intercourse or for IUI and for IVF. And we also have the GnRH agonist trigger for which we use in IVF. So the newer standard triggers are the dual triggers with the HCG and GnRH agonist, because GnRH agonist gives a physiological natural surge and HCG maintains the luteal function. So even the ESHRE 2025 guidelines recommends dual trigger in selected patients, especially low responders. So the newer triggers on research are the kisspeptin as an IVF trigger. It is a hypothalamic peptide that naturally stimulates GnRH secretion. So kisspeptin receptor agonist is a next generation trigger which can produce a more sustained LH surge, and it is currently under phase 2 trial. So there is also a study that shows progesterone can also be used as a ovulation trigger. We generally know that estrogen peak occurs before LH surge. Here they have given a new concept that there is also a small peak of progesterone before this LH surge, and they have been studying the use of progesterone as also as a ovulation trigger. So finally, there is the recent updates on ovulation stimulation for IVF given by the ESHRE in 2025. And what they emphasize is that they emphasize on antagonist protocols and tailored gonadotropin dosing as preferred practices in modern IVF. There are also emerging role for AI-based optimization tools for predicting ovulation, for deciding the ovulation stimulation dose and trigger timing. So this comes to the end of the topic. Integrating the physiology, technology, and holistic care is the key to improve women's fertility, sexual health, and well-being. Thank you for the opportunity, and thank you for the patient listening.
You finished just on time, on dot.
Thank you, ma'am.
Over to the judges for questioning.
Good presentation, Ashika. You have covered in depth everything about ovulation and the recent updates.
Thank you, ma'am.
Whether you recommend use of fertility tracking devices?
Yes, ma'am. That we might. I will not recommend though, because sometimes they are misleading. People won't know that they are not having regular cycles. Only with the advice of gynecologists and knowing that they are ovulating properly, we can advise them on ovulation tracking devices.
So any recent updates on ovulation monitoring? AI based. See, we talk so much about AI. Right?
Yes, ma'am.
Yeah.
Yes, ma'am. The AI based, they are bringing everything into AI based, from deciding the stimulation dose, for planning the trigger timing, and it was also a predictor for OHSS, which patient is prone for OHSS. So I think in the near future, AI will cover everything, and we won't have much work to do.
So recently there are certain apps like sensors. They are using sensors. That basal body temperature. That concept is again coming back.
Yes.
Like measuring the vaginal temperature and continuous monitoring of the skin temperature.
Yes,
so
ma'am. For every AI device, but the patient has to be a normal ovulating person to detect with ovulation kits. If they are anovulatory, I don't think this is going to help much. So they can get an advice of the gynecologist and then proceed with these apps.
Yes, that's good. So overall, it was a very good performance, starting from the basics and the
yes, ma'am. I had to rush
up
on the physiology because it is vast. Yes, ma'am.
Yeah, that was a very wonderful presentation, Ashika.
Thank you, ma'am.
Yes, thank you so much.
Thank you, ma'am.
Thank you, speakers, and thank you both the judges for taking your time off and being with us for this marathon CME. With this, we come to the end of the Yuva session, and now we go on to the main topic. The topic is on surgical vaginal rejuvenation. Since Dr. Sampath Kumari is a little busy, I invite my co-coordinator, Dr. Radhika Gauri, to chair the session. Over to you, Dr.
Good evening.
Over to
Yeah, good evening, everybody. And
Now you're not clearly audible.
Is it audible?
Yeah, now it's good.
Okay. I'm delighted to introduce Dr. Deepa Ganesh, who is a MBBS MS, and she's done her FMAS, DMAS, FIMA, and a diploma in minimal invasive surgery from Germany. and she has also done various degrees from France and robotics in USA. So she's an advanced laparoscopic robotic and cosmetic gynecologist, and she's a director and of the Laser and Cosmetic Gynecology Clinic and Laser Vaginal Rejuvenation Institute of India, first Indian associate of Laser Vaginal Rejuvenation Institute of America, and pioneer cosmetic gynecology in India. And she's done her fellowship in cosmetic gynecology in Los Angeles, USA, and also a diploma in advanced cosmetic plastic gynecology from Florida, USA. And also she has a fellowship from International Society of Cosmetic Gynecology in USA. And she's a member of American Academy of Cosmetic Surgery and European Society of Aesthetic Gynecology and International Society of Cosmetic Gynecology. She's a fellow of World Association of Laparoscopic Surgeons and International College of Robotic Surgeons, USA. And she is a managing committee member of IAGE in Tamil Nadu chapter and International National Training Teaching Faculty. She has over 20 international national publications and book chapters in cosmetic gynecology, and she's the first certified official provider of G-Shot in India. And we are going to listen to her interesting talk today. And let me hand over the session to Dr. Deepa Ganesh.
Thank you, ma'am, for the introduction. Hope I'm audible now. Am I audible?
Yes, ma'am.
Yes, you are.
Okay. Thank you, ma'am. Thank you, Sampath ma'am, Vidya ma'am, for this CME marathon. So it's really nice to see now, like, people are openly talking about sexual health. I think now the trend is really changing. I think we are more open about it, and more than that, I think we are forced to be like open because of present generation. They are coming openly and talking about it openly. And also we see the conversation is changing, the stigma is reducing, and the science is also evolving. So without further delay, let's go to my topic about surgical vaginal rejuvenation. I'll start sharing my okay. You able to see? Can you see my screen now?
Yes, ma'am.
Okay. So surgical vaginal rejuvenation. So everybody is talking about this word vaginal rejuvenation, and it's become trendy. And last few years, I think this is the most catchy and trending word. It's nothing but an umbrella term used to describe the range of aesthetic and functional procedures that correct and restore the optimal structure of the vagina and the surrounding tissues. So as I said, we've been doing vaginoplasty as a gynecologist, but it's again an umbrella term. Anything reshapes the vagina, we call it a vaginoplasty. Even creating a new vagina, we call it as a vaginoplasty. But again, like in cosmetic, it has a different term. As a regular gynecologist, we have been dealing every day with pelvic floor repairs, cystocele repairs, rectocele repairs. So it's not something really new, but there is a defect. We correct the defect suture. Whereas that's why you call it a RAFI. Whereas in plasty, you just give a nice shape. So vaginoplasty. So in cosmetic gynecology, the moment you say vaginoplasty, here you reduce the whole length of the vaginal canal, also the vaginal introitus with simultaneous plication of the levator muscles. Here they don't have any defect. The main complaint they come is because of vaginal laxity and vaginal looseness. So Dr. David Matlock from California, in fact, he's a pioneer who started this field, and he's the one who actually invented and trademarked this word called laser vaginal rejuvenation in 1992. And he said this procedure is done only for indication where patient come with the vaginal laxity and just to enhance sexual gratification. If at all, like she has along with it cystocele or any rectocele, you can correct it. Otherwise, the moment you say vaginal rejuvenation is just to enhance the sexual gratification, you do this procedure. And again, so just for this marketing purpose, that he used this tagline vaginal rejuvenation. In fact, I said he was the one who coined it. Otherwise, another loose synonym for vaginoplasty. Basically, like as a gynecologist, we've been doing all these pelvic floor repairs. So basically, colpopernioplasty became a colpopernioplasty, where he added the word laser. Instead of using a scalpel and cautery, he used a laser. So it gives a nice fine precision cutting. So the moment like the public, when they hear laser, it's so catchy. So that's why this LVR, laser rejuvenation, becomes so popular all over the world.
and he used diode laser for cutting instead of scalpel or a cautery. And as you all know, laser is like so popular. It's a bloodless, painless, especially in cosmetic. It gives a nice fine precision cutting. So aesthetically, at the end, it gives a nice good appearance. And main indication, as I said, for what they come is vaginal laxity, again because of multiple deliveries, aging, menopause, and also because of poor collagen and connective tissue. Um, Another is like colpopernioplasty. Now colpopernioplasty, again it's a combination of vaginoplasty as well as perineoplasty. So here there is no defect, only laxity is an indication they come to you with. So you tighten the whole vagina, that is vaginoplasty, along with the perineoplasty. So when you do functionally, you're correcting it, as well as cosmetically you're giving a nice aesthetic appearance. So this term was actually coined by Dr. Jack Pardo from Chile. So as I said, like, most of the gynec we have been doing, if you ask any, like even with your experience, even you would have done like, vaginal tightening procedures. But as I said, it should be both functionally, it should be corrected as well as cosmetically. So I had a doctor colleague who was coming to me for vaginal tightening, the non-surgical, where I was giving laser, but it was too lax. So I just told her, like, only surgical will going to give a permanent solution, because usually we say one size doesn't fit all. Just because you have a laser or radio frequency energy-based devices, it's not going to tighten. So again, patient selection is very important, and anything surgical is going to give you a permanent solution. So the moment I said, like, you have to go for surgical, she said, doc, like, I don't have real time, because the downtime is 6 to 8 weeks post surgery. So in between, like, she had some time, she had gone to a native, and she said her gynecologist who had delivered her, she said, I do it regularly, and like just 15 minutes procedure. And so she got it done there. So immediately after a week, she came back to me. She says, doc, you said it's going to take like 1.5 hours to 2 hours for the procedure, but she done it local and only 15 minutes. Just have a look. So this was a picture when she came to me. If you see, there's no cut, nothing, just like introital tightening was done. Like, 2-3 sutures was taken at the introitus and on the perineum. And she said just only like it was done in local, only 15 minutes. So if you see, functionally it was not corrected, because still the whole length of the vaginal canal is lax, as well as cosmetically, if you see, like, it looks like 2 vulvas she has now. So here, when the moment you say surgical rejuvenation, cosmetic gynecology, the main aim, you have to correct it functionally as well as cosmetically, you have to give a nice appearance. So basically what you do, as I said, like whole length of the vaginal canal, you have to tighten, which as a, like how we do a posterior colporaphy, the similar way. But here there is no defect. As I said, only laxity is only like, complaint she'll come to you with, along with the perineum, you just tighten it. So quickly, I'll just go through the video. And this is like post to delivery. Main, again, complaint was really laxity. So as I said, like the whole length of the vaginal canal will tighten. So you can use a scalpel, cautery, or the laser. As I said, laser gives a fine precision cutting. So you start dissecting the posterior vaginal wall, the whole length of the vaginal wall up to your desired, like, tightening. So you start like dissecting, and then you tighten the bulbospongious muscle on the both sides and come down, and then you actually tighten even the superficial perineal muscles, and you resect the excess vaginal tissue, and you just start reapproximating and tightening it. So usually they'll ask how much of tightening you should keep. Usually at least 2-finger digital examination, or at least 1.5 to 2 centimeters in diameter. Otherwise, she'll come to you with over tightening and dyspareunia. So this is the final look before and after. So cosmetically you correct it, as well as functionally the whole length of vaginal canal is tightened. So in cosmetically, where you see is both the labia majora will beautifully come and join in the posteriorly. So it gives a nice aesthetic appearance. So these are some of the before and after pictures. This is post 3 deliveries. You can see she had a complete perineal tear. This is immediately after surgery, and this is after 2 months. So just like 360 degrees, it just gives you a nice young look. So some of the before and after pictures I'll just show you. This again, all these patients came to me only for for enhanced sexual gratification. That's the only complaint majority they'll come to you with. And this patient, by seeing the picture, you could see she had a complete perineal tear. When she came to, she was 28 years old. At 19, she delivered, and it was difficult delivery, instrument delivery, 3 kilos. And again, she had a CPT, again, 2 times repair. And this is the final look she had. So she never had any fistula or any incontinence. The only complaint, she said, whenever she had sexual intercourse, because of the pressure, the fecal matter used to come out. So because of that, the husband, started avoiding her. She came and complained, cried, saying it's been almost 8-9 years since I had sexual intercourse with my husband, and it's almost about to leave me and going to get remarried. So she said, why can't I have a normal looking vulva and vagina of the women of my age? So we went ahead and did a vaginoplasty, perineoplasty along with the sphincteroplasty. Immediately the moment I showed this after surgery picture, it just boosted her self-confidence. She said, like, now I have so much of confidence, even if my husband leaves, I'm not bothered. So that extent, like, it really boosts her self-confidence. Otherwise, most of the time when the women come, the first complaint they say, like, my husband is not satisfied because of my laxity, or they'll say because the laxity is having an affair. So this most of the time, like, I'm sure even in your OPs, like, the women must have come and complained. This is commonly they come and complain to us. That also loses the self-confidence and self-esteem. The moment, like, when you tighten and you show the pictures, and immediately just boost her like confidence. So this is some of the before and after picture. And the first picture, like, immediately when I showed her, she was asking me, what are the two, like, extra, like, black color tissue I have? I said, it's a labia minora. She said, I didn't know, like, such a tissue existed. So we see most of the women, like, never even looked at their own vulva. They don't know how even the vulva looks. So I think now it's changing. Now, like, people have so much of awareness about the body parts now. And also we are also creating awareness. Like, I think most of the gynecologists also talking about it so openly. And again, this patient before and after, both vaginoplasty and perineoplasty, immediately when I showed the picture, she said, like, can you do something about my, like, the look? So again, I said there's another option where you can go for fat transfer. Now, again, labia major augmentation is becoming so popular for the last 3 years, I would say. Because nowadays they want to have that, like, nice plumped up look and young, youthful look. And also now the last 1 year, I would say, because of that GLP drugs, a lot of, like, people are going for weight loss, and also they're losing weight in the major. So now the new terminologies come as Ozempic vulva. So where they're losing weight even in the labia majora. So people are coming forward for the labia majora fat augmentation as well as with fillers. So that actually is becoming popular for the last 2 years, I would say. And again, both combination of vaginoplasty and perineoplasty. So immediately it gives a look. So this is immediately after surgery. You can just see, like, when I showed, separately it looked like two different patients, but it's the same patients, like nice aesthetic look also it gives, and young look. This is what, like, most of the women are preferring now. They're coming forward along with the functional, like, aspect. So more 90% we do a combination of vaginoplasty and perineoplasty. I would say 10% we do isolated perineoplasty, where mainly they come for the episiotomy scar and even for the revisions or some perineal tags. Also the patients come and say, like, I'm sure even you would have seen such patients coming and saying, like, during delivery they suture, they didn't do suturing properly. Because of that, like, I'm having pain. She'll come and say after 15-20 years, sutures olanga enak podla adnala, like, still I'm having pain, do something about it. Because of that suturing, like, I'm not having a sexual gratification with my husband. So most of the women come and say that. So for that, like, isolated perineoplasty we can just do. Otherwise, like, if she has a tight, like, vagina, no need of vaginoplasty, just a perineoplasty is fine. And also, like, nowadays people come for even aesthetic corrections where they don't like the scars, the episiotomy scars. So in that case, you can just correct the scars, and then you can aesthetically give them a nice look. Along with, now majority of people are coming for combination surgeries. So along with the commonly we do vaginoplasty, along with labiaplasty also they come, along with the fat transfers. So now it's like, at the same sitting, they want to get all the surgeries done. So perineoplasty again involves a reconstruction of the perineum, perineal body, vulvar vestibule, as well as vaginal introitus, as you know. But majority, like, before, when the moment they say, like, now on vaginal tightening, I think majority of the doctors, even the plastic surgeons, were only tightening the introitus, not the vaginal canal. So some patients, going back to the, like, plastic, they come to me and they say, like, it's only the, like, entry is tight, but again I feel very loose inside. So they just actually tighten only the introitus, not the vaginal full whole length of vaginal canal. So again, the different techniques of perineoplasty, you have a diamond-shaped excision. Most commonly we do for episiotomy scars. Then you have elliptical, triangle, and Z-plasty techniques. So as I said, most commonly we go for this diamond shape. And elliptical, again, depends upon how our scar is, how episiotomy scar and how we'll heal it. So accordingly, you just mark it and then, like, excise. Mostly we prefer doing a laser because, as I said, like, it gives a fine precision cutting, and mainly they come for they don't want the scar to be looked like that bad. So again, this is another elliptical excision perineal scar revision we did along with the labiaplasty. Triangular, again, it's more commonly, like, we do. And there's just a small video where we do the laser. See, with the cautery, it just takes like, less than a minute to excise a scar, but the laser, it takes time. The only advantage is it gives a very fine precision cutting. So you really need patience when you're cosmetically correcting it. And of course, it's bloodless, painless, and the edges will be very neat and nice. So when you suture, they give a nice aesthetic look. Only thing is, yeah, for this excising, this itself will take around like 10 minutes with the cautery. Within less than a minute, you can excise it. So when especially they come for the scar, like, they don't like the look. So most commonly for all these scars, we do with the laser. So as I said, now we're going towards a combination of procedures, like because of the downtime of 6 to 8 weeks, like they have to take all those like rest and take care of the wound. They want all the procedures as one shot. Like we do combination of perineoplasty, labiaplasty, ludoplasty, and then again all combinations, all first surgeries together. And these are little before and after pictures: perineoplasty, labiaplasty, and ludoplasty. Same before and after picture. And she came for vulval lightening. She wanted intimate area to be lightened using a laser and peels. Along with it, we did a colpoperineoplasty for her. And this patient, mainly she came for a scar, the revision. Like, so we did a perineoplasty. Along with it, she also wanted like, one shot. She wanted nice aesthetic look. So we went ahead, did the labiaplasty and hudaplasty. Again, post labiaplasty, she came for the vaginal laxity. So again, colpoperineoplasty we did. So again, fat transfer is said, like, no, now commonly, like, no, people are coming forward so that they can have a young look with a nice plumping on both the labia majoras. So this is some before and after. And same as I said, no, like we do also fat transfer. It nicely gives aesthetically gives a nice young look. And also majoroplasty also now the last, I would say 6 to 8 months, it's catching up. And when they have a really like, protruding majora, they just wanted to like, give a nice shape. We also combine and do with that. And now the another trend is vaginoplasty with hymenoplasty. Now, like, when this generation, like people want to give like, as a gift, like, for 5th anniversary or 10th or 15th, whatever. So that's a trend going on abroad. It's also catching up here in India. And another one, what I'm seeing now, it's like a lot of remarriages are happening, a lot of divorce and remarriage. So they just want to be how they were on the first night. So now the trend is now they're moving towards mini vaginoplasty with hymenoplasty. Just want to feel like a virgin. It's not like it's going to bring back a virginity, but just the feel of a virgin. So this is another commonly, like, we are seeing people are coming forward because of a lot of remarriages, or like, who wants to get married also, they want that tightening, the first time effect. So the importance is like whom to operate on. The well-educated patients who understands or what the real issues. Most of the women who come, they come and say the first thing like, no, my husband is not satisfied. He's just going out, he's having an affair. Just fix my vagina so that he comes back. So I just tell them, by fixing your vagina, your husband is not going to come back. So if at all you want the surgery, I'll do it for yourself, not to just to please your partner, because at present generation, the partners are changing, a lot of remarriages are happening. So every partner, you can't keep going under the knife. So I always say to her, like, I will do the surgery for you, not to just please your partner. So that really we have to be very clear with her. And also with reasonable expectations, and not taking the decision on the spur of the moment. Most of these women, like especially when they come for these vaginal laxity, they come so emotionally. They come and say, my husband is having an affair, you fix my vagina right now, I want him back. So at the spur of the moment, they'll say, do it right now, do it today. So again, you have to really give her a counseling, like, you should calm her down and just say, this is what you can expect, and do it for yourself. Not by fixing your vagina, he's not going to come back. That really you have to tell her that. And yes, safely, any cosmetic procedure can be done post 18 years. And then whom not to operate, very important, active gynecological, like, diseases, infections, poor immunity, body dysmorphic disorder, psychosis. Again, you have to send them for counseling. Never touch those patients, because one, they'll be never satisfied. They'll keep coming back to you, and more than they'll keep jumping to doctors, and they'll keep saying the doctor has done the fault and she didn't do my surgery properly. And another one, yes, of course, unreasonable expectations. And most of the times, like, no, they bring the picture and they say, I just want exactly like this. See, now vulvas become like a face. So whatever procedure you have for the face, everything is come for the vulva. Let it be like, all the surgical, apart from even non-surgical, like, you give, commonly you give fillers, Botox, PRP, peels, lasers, everything, whatever you do for the face, everything is now come for the vulva. And vulva is now treated like another face. So they also bring pictures and say, I just want, now another trend is a Barbie vulva, like, how Barbie face and Barbie body they have. Now Barbie vulva is like, really trending. And so we really have to like tell this is what you can expect. So you have to be very clear on that. So the aesthetic vaginal surgeon's intent is to elevate all these distress, psychological and physical pain triggered by unattractive and poorly functioning genitalia. And some gynecologists fail to grasp, as Meena Kumari ma'am said, we have to open up, we have to be non-judgmental and talk to the patient, ask leading questions, because when the patient comes, usually they'll be beating around the bush, they'll not open up. And they open up most of the times, as gynecologists, we just brush aside, we just say, just reassure and just do some Kegels, pelvic floor, we just send her back. But I think we have to really open up and ask her. I think that's what now most of the patients want non-judgmental gynecologists who actually talk about it openly, ask about the sexual health and what are the options available. Everything just really want to discuss. The line between the cosmetic and medical surgical procedure is blurred. Today, many surgeries are performed for both the purposes. Cosmetic plastic surgeons don't have exposure to intravaginal surgeries. With due respect to any plastic surgeons here, if at all they're listening, because I feel we are dealing with that vulva, perineum, and the pelvic floor. I think it's rightfully our domain because every day we deal with it. So we have the knowledge about all the intravaginal surgeries. So I think it's a time where we stop referring to the cosmetic surgeons for all these vaginal surgeries or vaginoplasty. I think we should take over and do, because previously we used to refer to any labiaplasty or vaginal tightening, we used to refer to the plastic surgeon. But what they do is just do the intraoral tightening, and they don't correct any defects. If at all they have laxity, most of the time they'll have some degree of cystocele along with the rectocele. So we can correct it at the same time, but they don't do it. So I think it's time where we have to take we have to do this. Field is about us. So we have to start doing it. And of course, you can have them in your team. Especially now, mommy makeover is really very popular, where from head to foot, post delivery, they just want to get in shape. So you have to have in a team along with a dermatologist and plastic surgeon, along with a sexologist, sexual counseling, sexual counseling. Now it's it's a holistic team work. So definitely you can have them in a team, but especially when it comes to any vaginal surgeries or the vulval surgeries, I think it's our domain. We should be doing that. And initially, all these ACOG and other society, Canadian and Royal College, they were not endorsing these procedures with the terms vaginal rejuvenation or cosmetic vaginal procedures because they're not medically necessary. But then, because of the rising demand from the patients, they said, okay, now and post COVID, they've said yes, you give them proper counseling and tell them the do's and don'ts and get the proper consent, and the surgeon should be properly trained to do these procedures. Otherwise, it's a fine line between the female genital mutilation. So all they said is the surgeon should be properly trained to all these procedures. And of course, you can just go ahead with that. So I would like to conclude saying, in hands of well-trained surgeons, all these cosmetic procedures are going to benefit millions of women. And of course, it's going to gain her good self-esteem and self-confidence. So whether a woman does it for a medical reason or aesthetic reason, it's her choice. Deliver what she wants. So these are some of my training programs. I give one-to-one hands-on fellowship training in cosmetic gynecology. And also take this opportunity to invite you for a third annual Congress and World Congress, CGCon 2026. It's coming up in November, third Cosmetic Gynecology World Congress. Thank you. I can take any questions.
Thank you, Dr. Deepa. That was a wonderful session. Very interesting. I think lots of doctors, many of them will have doubts. Revati ma'am?
Yeah. So
Any
only
doubt,
one
ma'am?
thing I would like to add is that many times when we do a vaginal hysterectomy for younger patients for prolapse or something like that, when you do you're not even younger patients, when you do the perineoplasty, thinking that we are going to prevent future wall prolapse, you tighten it too much, they get into problem. So you have to take care of that also.
Yes.
Because
And also, we have been doing this pelvic floor repairs, ma'am. Only thing is, when you're doing, we just want to finish the surgery and come. Nobody actually looked at the aesthetic part.
Yeah.
Nobody came on to how whether symmetrically both the majors are joining, whether we are excising the scar. I think now in this field, you have to give importance to that also.
Exactly. Yeah.
Even
Whenever we
during
do a
the
vaginal surgery, you please keep an eye on that also.
Yes.
Yes, ma'am.
I think
Even during the
even from our house surgeon time itself, we become a cosmetic gynecologist while doing
absolutely.
these scars,
episiotomy,
starts
yes.
from there.
Yeah.
try to, the mucosal, the border, you have to approximate it correctly.
Reforming the foreskin.
Skin,
Yes.
yes.
See, in
The
any
skin,
cosmetic, the word is a symmetry. It should be symmetrical
yes,
on both sides. And
absolutely.
yeah, that's the main word. Another thing is what usually they say is never overcorrect, undercorrect, because once you overcorrect, again, you can't revise it back. So if you ask even any cosmetic or dermatologist, they'll say always undercorrect, never overcorrect. And the symmetry is a key word there.
And what about these conditions like lichen sclerosis and those things? Do you deal with them all?
Yes, now for lichen,
Vulval,
lasers have come up, lasers with a combination of PRP. So that's giving a very, very, very beautiful, symptomatic relief. So we are moving from the non-steroidal treatment to lasers and PRP combination.
very good. Okay. And VIN as well, vulval intraepithelial neoplasia and vaginal inter.
Yes, ma'am. All those like the regular along with the lasers. Yes, ma'am. Now lasers are coming up. No, all the CO2 lasers where even recently for Seringoma, a new paper was released last year where ruling
Okay.
out malignancy, CO2 laser can be given. A paper was published on that. Like CO2 has become a treatment for that for the Seringoma for the labia majora.
Okay, wonderful. Thank you so much, Dr. Deepa.
Thank you, ma'am. Thank you, ma'am.
Thank you for the opportunity. Thank you, Gayatri.
Thank you, ma'am.
Thank you, ma'am. Thank you, Radhika, ma'am, for chairing the session and
Thank
Dr.
you.
that elaborate talk. Now we move on to the last session, which is a panel. I called upon Dr. Priya Kanappan, who is the moderator for this. She is a consultant, OB-GYN and a fertility consultant at Mehta Hospital, Chennai, and Garbharakshagi Rakshambigai Fertility Center, Chennai. She's also an executive committee member of Oxy Chennai. She's been the best outgoing student. She's been the receiver of the best outgoing student award and the best resident award from Manipal University. She's also done her fellowship in ultrasound and ICOG fellowship and from the MGR University in reproductive medicine. She was also,
Thank you, Dr. Gayatri. Thank you. So we'll go on with the introduction of our panelists. Actually, before that, there is one question in the chat box. Dr. Deepa ma'am, you want to answer that? Deepa ma'am, are you still there?
Yes, I'm here.
Yeah, any methods to prevent the laxity that we can suggest the patient other than Kegels exercise? Prevention better than treatment. So any patient, after vaginal delivery and other things, is there any other methods?
See, the natural method, usually what we say is the Kegels and pelvic floor exercise. But now all these non-surgical energy-based devices have come. Now Kegel chair has come because most of the patients, the moment you say they will not do, maximum they'll do only 5 or 10. But the Kegel chairs have come, which is very popular, where you just have to come and sit weekly twice just for half an hour. In that half an hour, it does close to 15,000 Kegel exercise. So either now mostly what we are doing is post as a delivery package, most of the doctors are combining energy-based devices, that is like a laser or whatever radio frequency you have. So after 3 months, they can come and have one session along with the Kegel chair, like a pelvic floor rehabilitation. As a combination, you can give that. So that they can do.
Okay, ma'am. Thank you. So I hope that that gave the explanation for them. So no further questions. So thank you, madam. We will be proceeding with that panel. So can I have my CVs for the panelists? Dr. Gayatri, you want to introduce or shall I go ahead with the CVs?
Ma'am, please go ahead, ma'am.
Yes. So my first panelist for today will be Dr. Vijayalakshmi Kandasamy, madam. Madam is a professor, Department of Obs and Gyne, Chettinad Hospital and Research Institute. She's done a UG from Stanley, PG from KMC Manipal, Karnataka, 20 years of teaching.
Thank you, Priya. I think.
Thank you, ma'am.
Yeah.
And she will be our incoming secretary of Oxy. So that is a new thing. We are very happy to have her for the next year. So congratulations, madam. And next will be my Dr. Nirmala Vijayakumar, madam. Madam is a consultant in reproductive medicine, Queen's Fertility Center, Tirunelveli. She is a done her MD from SRMC, MRCOG from the UK. And she's been the vice president of Tirunelveli, then the executive committee member of the IMA Tirunelveli chapter, and the president TTK chapter of the Tapisar. And she's won many awards to her accreditations. Welcome to you, ma'am. So can we have the next CV, please? Dr. Nazia Shaikh. She has done her MS from Andhra Medical College, Visakhapatnam, MBBS also from the Andhra Medical College, a fellowship in reproductive medicine from Sri Ramachandra Medical College. And she's worked at Dr. Mehta Hospital as a registrar, as SRMC as an SR, and currently in Sri Muthukumaran Medical College. Welcome to you, Nazia. Dr.
Thank
Sandhya,
you.
she's an assistant professor of ACS Medical College in Chennai. She's done her MBBS from Vellore and DGO from MMC and DNB from St. Isabel's Hospitals, Chennai. A gold medalist in Gynae Endocrinology medal exams at IOG in 2018. Presented papers poster with high-risk obstetrics and infertility as a field of interest. Welcome, Sandhya. Next. Dr. Monisha. Monisha is from Government Thoothukudi Medical College from MBBS and MS from SRMC and DNB. She's finished and now she's an assistant professor in Sri Muthukumaran Medical College. Presented papers in national and international conferences and journals with area of interest as high-risk obstetrics, minimal invasive gynec surgeries and infertility. Welcome, Monica. So if, yep, I'll share my screen. I would request all my panelists to please switch on your video so that, it'll be easy for me to see like who's there. Sorry, just give me a moment. Sorry, I could not put my panelist name there. Actually, it's a last minute panel. So if there is any spelling mistakes and other things, please forgive me. So started preparing in the last moment. I almost forgot and very sorry for that. So I think one of my panelists is not renamed. Is it Dr. Nazia, na, right? Can someone rename my panelist if that is possible?
Okay, ma'am. Sure.
So fine, thank you. So we'll go on with the session. So it is open to all. So I can hear some other voice as well. So can we mute that side? Yes. So we know that understanding of sexual dysfunction, we will be telling about a certain definitions and the importance of the overall sexual well-being, and a little bit about the common misconceptions and myths surrounding the sexual health. And we will be integrating the sexual health with primary as well as specialty care settings. So we are not going to go into exact detail of what a sexual medicine consultant is going to do there. We are going to give it if a patient comes to a general practitioner. So as a gynae, like how are we expected to manage? And if I have experts who are already practicing cosmetic gynecology, yes, I will definitely like to have your views on that. So going on that, what are the most common barriers a consultant will face on discussing the sexual health? Okay, and Dr. Vijay Madam take this question.
Yeah. So as you have already put it, see, it's not a topic that we broach with our patients. Most of the time we sit in a busy OPD and what Dr. Deepa Ganesh was saying, we would probably, address their, when they come for their antenatal checkup, we talk to them about delivery plan, but following that, postpartum, we do not address their issues as regards the pelvic floor laxity and their sexual health or questions particularly pertaining to their sexual freedom, and that is something that we don't address. And another thing is, yeah, there is a lack of training amongst the residents also. Although we stress about, so much on surgeries and all that, the vaginal surgeries, uh, we don't train them particularly for, various procedures that we had just had with the discussion, even be it a minor plasty procedures also. And probably it's, I think, an opinion amongst most gynecologists that it is, mm, the we might be it's a taboo subject even when we want to broach it with our own patients, and sometimes we feel that we might offend them if we ask leading questions along those lines. Those are some of the reasons why we don't really broach, but I definitely feel that yes, we should be talking about it, and what Dr. Deepa Ganesh was saying, we should be non-judgmental and inquire about their sexual health.
Yes, so even like actually Dr. Revati Madam has mentioned, whenever a patient comes for vaginal hysterectomy, we don't go and ask the question, is she sexually active anymore or not? We presume that, okay, the uterus has been out for quite some time, so mostly they're not sexually active. So that is how most of the, generally we think. I think we should change our perceptions. Nowadays, people are living healthy. So, they can have sexual life even up to age of 60, 70, or even 70 plus 80. We don't know. So there is no age limit, and age is just a number. So we just have to presume that every woman is sexually active, or if at all, if you can bring it into a consultation, then that will be better. So how do we normalize this sexual conversations? So Dr. Nirmala ma'am, can you take this question? Like when the patient
Yeah.
comes.
It's like we need to initiate having a conversation just naturally, like, how are you feeling today? So, how are your periods? Is it affecting sex? Bring sex into the conversation. Is your bleeding worse after sex? Things like that. And open ended questions like, are you worried about having sex? Is it like a good, or do you have any pain? And try avoiding medical jargon like dyspareunia, stuff like that. What else?
Okay, so one questions to all the panelists, which I have generally, like, do you feel intimidated or do you feel a little uncomfortable the moment you start talking about sex? Is there, from the patient or the attender, especially the a partner who's accompanying, do you feel a little uncomfortable when they start talking too much into the in depth of the sex, or is it any way you can give tips so that it can be avoided when people are going to start with a conversation? No, nothing like that. Then we will go ahead with the next question.
Sometimes
there is a
giving
bit
them
of
privacy helps. Giving them privacy, like, asking the staff to leave so that, it's a 1:1 conversation. Women will start talking more, especially if it pertains to having pain or erectile dysfunction in the spouse
So
or
now
premature ejaculation.
I agree with you completely, Dr. Nirmala. The only thing which I am asking is the man talking more? That is my question. Is the man who's sitting in your OP,
yes,
is he
yes.
talking more to make
Generally,
you uncomfortable? Or it's not like that? That is the wrong misconception we have.
yeah, as gynecologists, we are always more comfortable when the women speak to us. So when the husband takes over and when he starts, we do feel, at least I feel a little uncomfortable when he says and when he starts blaming his wife, and
So I
when it is an
think that is the
infertility
thing
setting.
which we will overcome by bringing it into a routine practice.
True,
So
true.
just not about fertility patient alone, because
Yeah.
fertility, I think everybody has the habit of asking how is your sexual life, because we know that is the priority of fertility. But for any other complaint, we are not giving much importance. So once we bring that also, I think that will work, and then we should we all know where to stop and where is our limit. So that is why we say we don't go very colloquially, we stick on to medical terms. So that's why it put them in place, we don't talk unnecessarily too much. So we'll go on with the next question. So whenever you talk about sexual consultations, they say about 5 P's. So this is what whenever I put sexual health, this came propping up too many times. 5 P's, 5 P's. So Dr. Sandhya or Nazia, you want to take up this question about what are these 5 P's about any
Yes, ma'am. Good evening. The 5 P's, which include first is about partner. You should ask the number of partners and also gender. Obviously, these days homosexuality is also there, and the nature of relationship. Is it like casual? Like there's also like a live-in relation, something like that is also their popularity. Then specific sexual activities like is it oral, vaginal sex, anal sex? Something more of the information is there from the social media rather than what they come directly to the doctor. That's why we should make them aware, ask them particularly open-ended question, not like offending them. Just first gain the trust and importance of the patient. We should be more patient while asking. We should not show curiosity or anxiety or whatever things. We should be more patient. Other thing is protection from STI, whether they are using any condoms, usually have to use, and or are there any barrier like cervical condoms, those things also we should ask. If the patient, either of the patient is having previous history of sexually transmitted infection, it means they are at more risk of having future infections. That also we should be a leading question. Then if they are having a pregnancy intention, or is just like that also will help if they are having trying to conceive
So if
or
they
if
come
they
to
are
fertility,
conception.
we will concentrate on more on fertility issues. If it is
Yes,
only
ma'am.
sexual dysfunction, then we are going to concentrate on those issues.
On the yes, ma'am.
So I agree with it. And the one more thing which you really lovely, very beautifully pointed out, you have to nowadays you have to always keep in mind that is we are having same-sex couple who are coming there. So like, the girl to girl relationships are more common. So we have to keep that in mind. And again, like, these kind of other things where, other than vaginal sex, the other things are also common nowadays. So think of these things as a part of your questionnaires when you're going to ask them. And another which is important is actually whatever they see in social media. Nowadays, few of the couples, they really want to explore and see whether it's happening or not. So sometimes even group having a group, like physical contact is also coming up. There are very few patients, rarely they come to your OPDs to ask about that. So just be ready for that. Don't show your face like, oh my God, really? So those things, if you can
So
avoid, I
yeah,
think
that,
finally.
yeah, that non-judgmental attitude is very
Attitude
important.
we
Number
have to
one.
develop for that.
Number two, I think as gynecologists, we should also, focus on prevention, STI prevention,
Yes.
and appropriate barrier contraception and vaccination for HPV. I think we should talk to them about that also, once we
Excellent.
have
Completely agree with
approached
you.
that. Yeah.
So, like, is there any ethical issues, like, Dr. Monisha, can you take this question? Ethical
Yes, ma'am.
issues while you're talking about this patient information. Do we think of something else?
Yes, ma'am. The ethical issues, first of all, the patient must consent for the examination and for the treatment we offer, and the risks, she should be made aware of all those things. And also the confidentiality. She's coming to the hospital believing in to the gynecologist. She's telling them all the intimate informations, and the doctor has the responsibility to protect her privacy and confidentiality. But at the same time, uh, Right to Information Act, they prioritize the transparency. So it is like a gray area, whether there is a breach of confidentiality or what. And a mandatory reporting and trust must be there. In case of POXO, if an adolescent girl less than 18 years comes to the OPD and complains of the sexual abuse, we have the responsibility to uh, intimate to the concerned authorities. And the digital data security, nowadays all the hospitals, the datas are being entered in the computer, and the hackers can have the access to open it. And there are chances of inadequate data anonymization, which leaves the patient vulnerable to misuse. So these data can be stolen by someone. So this also becomes a challenge for a doctor.
Yes. So though we say that all the electronic, like hospital records and the teleconsults you can do, but still the breach of privacy of the patient and it can be hacked. That is one. Thankfully, India we are not getting cases for breach of confidentiality as of now. But abroad, once these things get leaked, they get sued for that as well. So we have to remember that in few years down the line, even we will also be getting of breach of patients this. Okay. So once how do you bring up AI in these? Everybody wants AI. So shall any patient with sexual dysfunction, Dr. Sandhya, can you take it? So she can just go to Chat GPT, do whatever she wants, get it done at Chat GPT, or what do we advise on that? What is the use of AI?
Uh, AI, maybe we can have consultations, ma'am, and maybe algorithm symptoms. We can have some technologies. If this symptoms, they can have this. They have to go for doctors, like especially for the infections, ma'am. If they're having this discharge, they should always come to doctor and check it. Maybe like that. And contraception. It's very, especially in sexuality, that's a very important aspect, ma'am. Especially emergency contraceptions, so they can have a immediate consultation with doctors
Yes.
and get this.
And actually, like this teleabortion is for the abroad people. We don't,
Not
start like that.
Not in India.
Because yes, the chance of ectopic is still very high for us, and our patients are not compliant and they don't come for follow up. So for our services, it's little difficult. So like for the other things, it's okay. So, like, I think we have already given these things. So, you just have to highlight, you just have to build the patient's confidence, build a rapport. You will, overcome the personal and structural discomforts for the patient and bring them into a confidentiality. And always, like, it's an implied consult for OPD. So, if a patient comes to you, it is implied that she's come to, give the details to you. And always, there should be a ethical aspect as well. So, let us go to my case. So, this is a patient who's a 38-year-old. She's nulliparous, married for 17 years. Okay, known PCOS, a BMI is 19. So she's a kind of lean PCO. She has regular cycles, underwent 5 IVF cycles. Now comes with dyspareunia for 6 months. So what is the first thing which you're going to do? Dr. VG ma'am, you want to take it?
Yeah. So see, she's had multiple failed IVF attempts earlier. A
Yes.
thin-built woman, obesity is not the issue there, and probably she could be having endometriosis. Even some women, mild endometriosis also tends to, manifest with dyspareunia. Not just that she should be DIE. And also she's had multiple oocyte retrievals, having, undergone the cycle 5 times. She could be having some, stenosis and some fibrosis there. That might be the reason for her dyspareunia. But always it's better when they complain of dyspareunia, we need to find out, could there be even some local infection which might be the reason. So is it a deep dyspareunia or is it a superficial dyspareunia? That is something we should be, examining her and then make a appropriate diagnosis.
So
That's
first
very
you're going to
important.
think of is IVF relating in endometriosis, infections. It can be even pelvic
Yes.
PIDs or it can be some
Yes.
superficial infections. And sometimes with repeated things, we can even think of ovarian failure, even in a PCO woman, multiple times pricked or something we don't know. So Dr. Nirmala ma'am, being an IVF consultant, so how are you going to go further? What is
So
your
clinical examination, repeated IVF, older patients. So maybe she's hypoestrogenic, poor ovarian reserve. So check rule out ectopic vagina and vaginitis. At the same time, when we do the pelvic examination, if there's a deep dyspareunia, she will have tenderness in her pouch of Douglas. Transvaginal scan can rule out the sliding of the bladder and the pouch of Douglas over the uterus. That can help. So PID, endometriosis, that's what we need to think about deep dyspareunia. If it's superficial, then dryness or some cracks or vaginal infection, maybe a lubricant will help.
Yes. So now it's deep. We have already told you it can be either endometriosis, 38-year women. We can even think of the sister part of endometriosis, which is adenomyosis, quite common in the middle-aged women. So we are going to think of that. Adhesions and PID we have already mentioned in these women. So fine. So now this patient did not have a deep dyspareunia. She had only superficial dyspareunia. So Sandhya, you want to think what are the things you are going to think of? She didn't have deep. She had superficial dyspareunia.
Ma'am, as madam already mentioned, she could be having dryness.
Yes.
So because of all the stimulation and hypoestrogenism, she can have dryness.
Okay.
And scarring, fibrosis due to repeated retrieval procedures.
Quite rare usually because Dr. Nirmala, you must have done a lot of IVF
pain.
patients. Have you seen the scarring, vagina getting a
Yes,
problem? Once you search in the Google, it gives you all the rare things. Okay. But quite rare. Most of us, we have not encountered these type of scarring. Unless and until it's very traumatic or something else. So, but the more important thing which you have to remember is secondary dyspareunia can be because of vaginismus as well. Okay, it is like how you have this tocophobia, like the patient gets a fear after labor. Same thing, the patient who's had a long period of infertility, she's married 17 years, underwent multiple cycles of IVF. This patient will definitely have a psychological fear just to have sex because she doesn't want to go into the fertility aspect again. So
True. And another important thing is, as you said, rightly said, she's 38 and always sex has been in relation to, for her perception, only
children.
fertility. Yeah.
Yes.
So when it is multiple failed, there is a lot of psychological overlay also.
Yes.
So we should look at that as well. Is that manifesting as dyspareunia? She
Yes.
is very upset with the so many failed IVF cycles.
True. And
That could
actually,
be
that
there.
was the reason for this patient. We evaluated her. So, Dr. Nazia, you want to comment on the Q-tip test? Usually we don't do it, but what is this Q-tip test? For what condition does it?
It's used to differentiate vulvodynia means the pain due to nerve inflammation or nerve pain or due to secondary vaginismus due to weak pelvic muscles or tight pelvic muscles. Secondary vaginismus, actually, it is there if the patient is not having gratification or sexual pleasure. if most probably due to infection or the fear of anxiety of sex that causes secondary vaginismus. This is nothing, it's like OPD procedure only, it doesn't require anything. Just what we have to do is first ask the patient to lie down in lithotomy position. Then we tell the patient to relax, and then we'll take a cotton tip or a swab. Slowly, gently from one side of lateral side of thigh, we gently strike the vestibule starting from point 1, 4, covering the points like 7, 11, like that we have to do. If it is due to nerve pain, pain due to inflamed nerves, she will have a positive test. If due to secondary vaginismus or due to pelvic muscle related, then first she will have anxiety and fear. Even before we perform the test itself, she will have more anxiety. So it doesn't rule out completely. It's just to rule out vulvodynia, especially, I think.
So whether you is it a burning sensation, pain, or is it an involuntary contraction? So that is what we are going to basically see in a Q-tip, or even when you're going to examine, this patient is going to tell you that. So how do we treat a secondary vaginismus? Dr. Monisha, you want to take this?
Yes, ma'am. Secondary vaginismus, usually the women had a previous pain-free sex, but now she is experiencing the pain during intercourse. So first thing we advise is the pelvic floor exercises for her, and then the vaginal dilators, serial dilators she can be using at home, and also the stimulation devices also she can use, and the counseling for both the partners. Cognitive behavioral therapy is essential for them, and psychosexual counseling based on what is desirable for them, what are the needs, and what is the negative thing that is affecting during the sexual activity also should be addressed. And medical interventions in case of atrophic vaginitis and all, the topical estrogen creams can help, and also the water-based lubricants can help for the vaginal dryness. And reversibility, always you can reassure, because secondary causes are usually treatable, and doctors can provide with the support for the lady.
Yes. So this is based on this superficial dyspareunia, the secondary vaginismus without any other cause. So this is secondary in the sense that they are not initially they were able to have sexual life and now they are having it. And this pelvic floor is more of relaxation, not the exercise. So we are not giving them this one. So the next case we go on that. She's a 30-year-old para 2 live 2. She has previous 2 normal vaginal delivery, and now she is come with a complaint. The partner is not getting the orgasm due to a lax perineum. So this is the complaint. The patient has come to you. So Vijay madam, what are you going to do for this patient?
I would say she's the right case for Deepa Ganesh, madam.
So you directly
Yes.
refer it to her.
No,
And
I
so now
think.
Deepa ma'am has come. Okay.
Yeah, see, we'll have to examine her first, as there could be a poorly healed episiotomy, and there might be scar tissue which is causing. There might be a small caruncle there, and that can be the reason, and also laxity of her, the pelvic floor. And many of the women, we do see some degree of a cystocele and a small rectocele, and lax perineum, lax vagina, which may be, the reason why her husband is not able to achieve an orgasm. But we should also address his issues also. Does he have other issues, like, sometimes the women come and complain to us, the husband, because I have seen this in practice also. He is a diabetic, hypertensive, on
I
multiple
have also
drugs,
seen.
unable to reach, an erection properly, and
And he
not
blames.
able to achieve an orgasm, and he kind of lays the blame on the female partner.
Nice.
So I think we'll
Yeah.
have to address both issues. But as gynecologists, we have to see, because it is a complaint that has come, we will have to, examine her completely and talk to her. Counseling.
Yes.
And
So now Deepa
yeah.
ma'am, this patient has come to you, but the pelvic floor is fine. Her pelvic floor is absolutely okay. No obvious scar tissues, nothing is seen there. Episiotomy is pretty well healed. It looks like skin only. There is not even a puckering, nothing there, and no pelvic organ prolapse. Now, what are you going to do for this patient? Absolutely normal on examination.
Yeah, only complaint is a lack of satisfaction, right? So in that case,
On
you
the
can go
male
for
partner.
nurse. See, male, as madam said, like, you have to see whether he's got ED or anything, he's just putting a blame on them. Majority of, like, men put the blame on women, and they go into inferiority complex and just come to us. So again, like most of the patients, like, they come and ask, please check my veg, and I say whether it's loose or lax. So I usually say, I cannot say whether it's loose or lax. So it all depends upon the partner, because sometimes it looks so lax to me, but they say they're very, like, satisfied with their sexual intercourse. Whereas, like, I've had 20-year-old unmarried girls who come and ask, do a surgical tightening for me, who's not even had any kids. They say, like, I'm not having partner like satisfaction. Maybe, like, no, he's got a micro penis. We don't know, because we don't know, like, no, how the other partner is. So the first question I ask is, like, whether you're satisfied or not. I ask. If she says yes, I also feel that laxity, I'm not satisfied, then I'll offer her. If she has completed a family, surgical surgery gives a permanent solution. Otherwise, non-surgical, she has to keep coming every month. And it stays only for 6 months. So every 6 months, she has to come for the maintenance of laser tightening. So if there's no scar and, like, she has little only minimal laxity, of course, you can directly go for the non-surgical laser tightening.
Okay, so these are patients, sometimes they come and ask us. So I'll give this question to Nirmala ma'am, if that's okay. So she says, like, my husband is not satisfied with the vagina. Can we do a oral sex, because I don't even want to get pregnant? Let me finish it off with that. I'm okay. There are a lot of patients who come and ask me this. I was, like, very surprised, because I would really think, like, really you are comfortable with oral? They say, yeah, doctor, at least we'll not get pregnant. We'll just finish it off once and for all and it is over. So what will you advise? You say, like, yeah, go ahead, that is a good thing, or is there anything we should say apart from that?
Definitely. I mean, why not? Oral sex is still sex, and the common consensus is, as you grow older, especially this is a long married couple with 2 children, you need more variety, isn't it? So penetrative intercourse is not the only kind of sexual intimacy. So oral sex is, and all other kinds of sex of all variations is definitely to be encouraged. And also maybe as they grow older and they have erectile dysfunctions, more than the vagina, the hand on the mouth gives a firmer pressure and better pleasure for the male. So I wouldn't rule that out, but her pleasure is also important. So you need to ask her,
Okay.
are you okay with it? I mean, what do you think? I'm sorry about this.
So we have a few next coming questions of her pleasures as well. So I've had that, because we wanted to keep it as a Valentine's Day. So we wanted, like, full
Yeah.
bound the things about that. So any investigation you want to do for this patient, you have examined her perfectly, all right. Pelvic floor normal. Vagina is, like, for you, it looks tight. As a gynecologist, it's looking tight. There's nothing major for that. So are you going to do this one electromyography? You're going to do a perineal muscles, whether these are, like, strong or not. You want to do something like that, or any ultrasound? You want to do a perineal ultrasound? You want to see any sphincter, something, or anything you want to do, or nothing? No investigations, any role? Anyone wants to take this question? Dr. Nazia, you want to take?
We just have to rule out infections, ma'am. I don't think all this sphincter tone and all will be done for this patient. As ma'am said, like, it is for that patient should have that
Individual
gratification.
perception.
Not
So,
about
like,
laxity, yes, individual perception.
So Deepa
So
ma'am,
there's
you
no
don't
role,
do
ma'am,
this
current.
at all. This electromyography, so putting, like, I read, like, we were just reading, ma'am.
No.
We're
We
not
just
doing.
don't. As I said, no, always give first importance to the women. You ask her whether she's satisfied. See, the husband can put 101 blames on her. So the first thing I always says, don't do it for, like, you're pleasing a partner. If you're not satisfied, I'll help you. I'll give you options of non-surgical or surgical along with the Kegel chair you can give. If she says, yes, I'm
What is
also
this
not
Kegel
satisfied, then
chair
you can
that
give
she
an
was saying,
option.
ma'am? So is it like
It's
only
a high from chair, high intensity focused electromagnetic chairs. Basically, it's a chair. You must have seen all these massaging chairs, right? It look exactly like that. But when you sit, like, there's electric stimulation directly to the pelvic floor muscles when you sit. So it does in half an hour. All you have to do is just fully clothed. You just sit there for half an hour.
So
In
it's a
half an hour, it
normal
does
chair. It
15.
doesn't have a cone or something into the vagina. Nothing like that. Nothing goes inside.
No, just a normal chair, like a massaging chair. You can just sit straight,
Okay.
and it gives a nice stimulation to the pelvic floor when you sit right on that. Only that area it comes, and it does close to. Again, depends on the brands which you're going, and now even chairs are coming. Even Chinese chairs are coming. So, but the nice good ones you go at least minimum 15,000 Kegels it does in half an hour. So usually we advise them weekly twice. You just come, sit and go. So that also gives a nice tightening along with the non-surgical like laser. You can just go if it's not no. As you said, like, pelvic floor is fine, but again, you ask her if she's not satisfied, these two options you can give her.
Got it, ma'am. Yes. So management, as we all said, we are going to give them the Kegel exercises. Yes. So we will always try with conservative. We'll tell them not surgical, and then otherwise, then we will send it to Deepa ma'am. She'll go and go ahead with the vaginoplasty or perineoplasty. So, or like whatever madam feels is there, and definitely conservative is the first line, and then we will go with all these things. So let me go with my next one. We have a case 3. Okay. She is a 25-year-old married for 2 years. She comes with a complaint of not achieving orgasm. So my question to Monisha, you want to take it. Is female orgasm important? Is it needed for the female to get it?
Yes, ma'am, definitely sexual satisfaction is equal for male and female. But there is always a tendency that once the males get satisfied, the female partner is not equally getting that. So the physical relationship and the bonding and the foreplay is lacking. They directly get into the penetrative intercourse, and the female gets not get satisfied about it. So the bonding breaks, and she's not getting the satisfaction that might lead to some polygamous relationship also. And for the mental and physical health well-being of the women, it is very essential.
Okay, so anyone can comment on what are all the physical health benefits these orgasms have shown to be low linked? Anyone?
Yeah, actually, female orgasms, it is it does release the release of hormones, especially the serotonin and all. It's very important for the female, the well-being as such. It does have a lot of, it's a stress buster.
Yes.
And
And
so
it is also
even in stable monogamous relationships, sometimes the women tend to be overstressed in their jobs and career oriented and all that. But if they're not having an orgasm, it tends to tell on their, overall life and their relationship with their partner and their family members. So I feel that, yes, it is definitely something that.
actually, when we browsed, no, madam, it had a role in migraine. It induces sleep in the patient as well. So definitely, whichever disease you're relating to sleep, all your metabolic diseases, you can relate it to orgasm as well. So that is what, like a little bit of new things for us. So like,
And also it is something that is created by nature. It's not just that only the males should have orgasm. So women are also supposed to have, and the female anatomy is structured like that. So I think over the years, the women have been put down by men across centuries in all civilizations.
So we'll go and
Where
women's right is orgasm. Get a quote and we will fight on Valentine's Day. So Sandhya, you
true,
want to
very
take
true.
up this question. So how does a orgasm happen? Like, for female orgasm?
Ma'am, first, there should be some stimulations like the physical stimulation in the clitoris, in the G spot, anterior vaginal wall, their mons, they get, and then they have to, that intimacy gets them the
Yes,
feel
foreplay
and,
as well gets the orgasm. So it is not
yes, ma'am,
only
okay.
your like local area, even the foreplay.
Yes, ma'am.
Yes. And second is more of mental imaginary is what the orgasm is. So if your patient is already gone into a 36-hour shift, she's tired, she's like, she just
Yes,
wants to sleep. And that time, definitely, she will never attain an orgasm at all. So I think when we are
Even
asking.
when she's stressed or depressed.
Yes. So most of the time our patient come back to us, mostly they'll be lactating or mostly they'll be taking care of the child, and they will also be joining their job maybe that 6-7 months after the maternity leave. They've also joined a job, come back, take care of the kid, do breastfeeding, do pumping, and take the home, everything, and then they come and complain no orgasm is coming. So I think you have to see the holistic picture rather than to focus on that. So now, like Dr. Nirmala ma'am, like, do you want to just comment what are the probable causes of female orgasmic dysfunction, FOD?
As you started off well, it could be stress and sleep loss or depression. They could be for women, especially if they feel that they don't look good, they have less confidence to undress and they have less desire, which is why the whole thing of cosmetic gynecology comes in, because women are very much aware of how they look, and they have to be desirable to themselves to feel sexual pleasure. And then biological factors like, they might be dyspneic because of cardiac problems, obesity. There might be mechanical problems because they are not able to flex their hips. And also, psychologically, they are inhibited in the way they were brought up, so they're not able to experience pleasure because they've been taught that, it's a sin to enjoy sex.
True. There are few patients who come back and tell me that their mother has always been very strict that never to think about sex before marriage. And now they are both 30s, but they cannot come, like bring it into their mind that it's okay to have it after marriage. So,
Sure.
that psychological trauma becomes too much. So, how do we treat these patients? So, Dr. Monisha, you want to take it?
Ma'am, the first line would be to address the problem, like the first behavioral treatment, directed masturbation must be, the patient must be trained to how to masturbate. She should know about the anatomy of her pelvic organs and where all the G spots or whatever is located and what are the stimuli she can give so that she can self masturbate. And the sensate focus structured touching exercises can be taught to her. Use of sexual enhancement devices like stimulation devices can be used, vibrators can be used, and psychotherapy should be given. A cognitive behavioral therapy address about the positive effects and the negative thoughts about the sex, whether she is satisfied or what are the negative things she is having about the sex, and sex education must be taught. And couple counseling is very essential because only after hours of talking they tend to understand each other so that they will build a positive vibe and have the pleasure. And medical treatments include uh, reducing the dose of SSRIs or switching to some other drugs like bupropion. And hormone therapy for postmenopausal women, estrogen creams can be advised. And for younger women, lubricants can be advised. And pelvic floor physiotherapy helps much for the orgasmic dysfunction.
Yes, very well. So, you've given
I would
all the
like to
information.
add.
Yes,
Can
ma'am.
I? Yeah.
Yes, ma'am.
See,
Yes.
now in cosmetic gynae, another popular one is the O shot and the G shot.
I
O
was
shot is
about to
orgasm.
ask you that, madam. G spot amplification, but you came back before I asked. So
Yeah.
tell me, madam. Yes.
So O shot is an orgasm shot and G shot is a G spot augmentation. See, a lot of women, like, as you said, like they never had an orgasm. They just come and ask, ma'am, I never had an orgasm. Just give me a G shot. They think all these are like magic drug and magic injections. Just like they give an injection, they just boom, going to have an orgasm. It doesn't work that way. See, first, as you all be discussing, the woman has to explore her own body. She should find out where the sensitive spots. The main key is the communication with the partner. She has to be with the right partner, right communication at the moment, not thinking about like some fight or argument she had with her partner and think she never will achieve orgasm, how much the guy even tries. So
True.
that first thing we have to tell her, explore your body and then find your sensitive spots. And spot augmentation, usually what we do is we give something called a filler. At that one spot we just enhance it so that she gets a multiple orgasm. Only for a woman who's sexually active, who's having a normal vaginal orgasm, who wants to enhance it. Not for a woman who never had an orgasm, you give a J shot. It doesn't work that way. Only who's having, like, I'm having an orgasm, I'm just having one or two, I just want to have multiple, 3 4. In that case you can go for G shot, G spot augmentation. O shot, orgasm shot, is where we give a PRP, just mainly to rejuvenate the vagina, where, like, because of the aging or post delivery, because of the hormones or vaginal dryness, the sensitivity is come down, or because of dryness, there's no lubrication, she's having a painful intercourse. In that case, we give PRP around the clitoris, around the clitoral hood, on the anterior vaginal wall, around the G spot area. So basically, you're making it more sensitive, that area. So that again, like, it becomes more sensitive. Arousal can increase in case she's going for clitoral orgasm. The clitoral arousal, like, it'll be it'll be much faster along with an orgasm. So this is the main difference between O shot and G shot. Again, very important, which you have stressed. the antidepressants and anti-anxiety drugs. Nowadays, I think post 35, 40, most of the women are at the sleeping pills or antidepressants. So that is definitely causing them female sexual dysfunction. So when you're giving O shot or G shot just to enhance, you have to make sure you have to tell her you have to reduce those dosage. Otherwise, whatever treatment you're going to give along with a combination of lasers or even the chair to tighten, it's not going to work. She's going to come back and say whatever treatment you're giving, it's not working because she'll be on these drugs. And this really you have to ask the history. Most of the patients will not say. When you really ask the history, any other drugs, slowly they'll come and say, like, yes, I'm taking antidepressants for the last 6 months. So only when she tapers down, even all these, like, whatever treatments you're giving, like lasers or O shot, G shot, or the pelvic chairs will actually work. Otherwise, she's going to come
Where
back
is
and
this
say,
point of G shot? Where do we like the G
see,
spot?
G-shot, again, I said, again, it's nothing called a direct, this is a spot. It's nothing like a switch on and button. Again, she has to explore a body. But I usually tell all the patients the G-spot for women is in the mind because she has to be at the moment. There's no magic spot like where you give. But usually, like, who's having a vaginal orgasm, definitely she must have explored a body. So she herself will tell, like, when we examine, we ask her where is your sensitivity is increasing, she'll be able to say because she's already had a vaginal orgasm. So wherever it is, we give on that spot, we'll mark it and just give like 0.1 or 2 cc of the hyaluronic acid. So basically it enhance and it'll make it super sensitive. So she'll say, I want 3 to 4 orgasm, who's already had an orgasm. Not for a woman who come and says, I've never had an orgasm, please give a G-shot. Doesn't work that way.
Yeah. So that is a little bit of information for general gynecs, I feel. So, like, if you're going to send it to Deepa madam, also remember that if you've already had an orgasm, you can send it to her. Otherwise, it's not going to work there. Then you have to send it to clitoris. So, like, now the next question. So, we have a fertility expert, Dr. Nirmala, is with us. So, like, is this orgasm needed for conception? Many patients come and ask us, I never have an orgasm. Is it needed for conception? I'm not conceiving because of this.
None of the evidence does not suggest that it's absolutely necessary for conception, but it helps at least. It reduces stress. It increases oxytocin, it increases bonding, and it helps you have more sex more frequently. If your orgasm is good, then you will not try to avoid sex during the fertile period. So in that way, in an indirect way, it helps with pregnancy. But is it absolutely needed? No evidence as yet.
Yes, ma'am. So there was an old theory which said some upsuck theory where the uterus is supposed to contract during the orgasm period, and that time it sucks the sperm. That was a very old one, and now that is like recent evidence
No, I
has
would
nullified
actually,
that.
I think I
Yes.
would beg to differ on that because during ejaculation, it is only after post ejaculate for the sperms to start, get the sperm, it has to liquefy and then the sperm start migrating upward, isn't
Yes.
it? So
That's what.
does it
So that's
happen
what, ma'am, I was
immediately?
saying.
And
This is
orgasm is also a very transient experience that the woman experiences.
yes.
So
So
I
like
don't think this
this is
theory
no
really,
role. That is what I was
yeah,
about to complete.
yeah,
This was
true,
an olden theory, which
true,
now it has been disproved because we know that the
disproved.
sperm lives there for like say around 48 to 72 hours there, and anytime it can just go and do the fertilization. So they need not have the sex at the time of ovulation itself. So like this theory is disproved. So the patient does not have, but anyway, for their overall bonding, yes. And Madam Nirmala ma'am
Yeah,
has beautifully expressed. If you want to have consistently want to have sex, the patient should feel the orgasm for her to have a stress-free,
yeah.
positive outlook towards having a coital function. Yes. So I think this will be my last case. We're not going to go boring with that. 42-year women, paratool live to married for 15 years. So now she's complaining of reduced libido and significant pain during intercourse. So what do we do next? Dr. Nazia, you want to take it?
Yes, ma'am.
Reduced
She's
libido pain.
42-year-old. Yes, 42-year-old with reduced libido. Maybe perimenopausal age group. So first thing will be reduced hormones, estrogen or progesterone. And also 42-year-old, along with that, she'll have different comorbidities also, might be pre-diabetic, diabetic, that and all. And also stress from the constant work pressure, everything. All this will affect. Due to perimenopausal age group, vaginal dryness should be ruled out. Like we can give her local estrogen creams or lubricants, like watery gel like that. The other thing is psychological. I told you like sex should be a stress buster. I mean, when we have gratification, that stress will go out. but it should not cause itself a stress. Sex should not be stressful. So that should be the psychological thing should be there where we tell them to have she should be mentally or psychologically prepared and sit with that first intimacy means first have a physical intimacy and then later go on with that sexual thing.
So in these
That's what
patients,
I
how many of you want to give tibolone or any testosterone?
Yeah, I would like to give her a short trial of tibolone and see.
Yeah, most
Yeah,
of
I
us
was thinking because when they come
something
to
we have to
us,
give.
yeah, apart from prescribing calcium and
Yeah,
doing
reassuring,
yeah,
go have a psychological thing, yes. But most of the time we sit and
but
talk.
like
Sometimes
what
we have time, yes.
like Dr. Nazia said, if it should not be a stress for them, at the end of a very busy day, the woman doesn't definitely her libido is going to be on the lower side. So it's important that we address or take a proper history, see exactly what is the reason for her reduced libido. There might be so many other contributing factors.
Okay.
She's
So I
42 in
think
the
we have,
peak.
I'm sorry. So I'm almost like, we have end of there. So I would like to, I ask each of my panelists to give one takeaway point for the audience. So one point per panelist regarding sexual
Um,
health in a woman. So Dr.
Mom, first we should be non-judgmental and open, and we should make a comfortable environment for the patient to talk about their intimate
completely agree with you.
problems.
Yes. So Dr. Monisha?
Ma'am, the awareness should be increased among the people regarding the sexual health because previously years back, pap smear was only taken for patients coming for gynecological examination. But now patients started coming directly to the gynecologist to do pap smear done yearly. Likewise, for sexual health talk also, they should approach the gynae without any hesitation, right from the adolescent period to the menopausal age, irrespective of we should also have the responsibility to have a non-judgmental attitude towards them and address. So awareness should be increased among the people.
Yes. So Dr. Nazia?
Yes, ma'am. I want to say one thing. Doctor or gynecologist should be the first point of contact for the patient with these issues.
I
Rather
will
than
not
they
say
should not search in
madam
social
first.
media or, not go for social media or close by relatives or who have like a little knowledge. They should not approach them. They should go to gynecologist. They should be the first point of contact. They should gain the trust. First is we should not judge and we should include in routine history, ma'am, like how we are asking, is your periods regular, any diabetic, like that. One point, like open-ended point, just how you are feeling these days. Is your sexual satisfaction good? How is your relation with partner? I feel it's should be part of our regular history.
Yes, got it. Dr. Nemla, ma'am.
Yeah, if somebody has a female orgasmic disorder, then that has to be corrected by either cognitive behavioral or directed masturbation or using sex toys instead of referring them for a O shot or a P shot.
Okay. Yes. And madam has already told that if they've not had orgasm, don't refer
Yes,
for any
yeah.
shot. It's
So, but
not going
they
to
have
work
to
out.
discover their own body and may see what makes them come before going for interventional procedures.
Yes. Viji, madam.
Yeah, as gynecologists, I feel we should be the ones advocating for our women. We advocate a lot for our women for their sexual freedom and sexual health. Also, we should be their advocates. And we should definitely, in our gynec history taking, sexual health history should also be part of that. And the young, crop of doctors, budding gynecologists who come up, they all should incorporate it into their regular history taking, and we should, make it an open discussion so that the women do not, as you said, rely only on social media and other platforms, and informed decisions or informed advice should come from our side.
Yes, ma'am.
So
And
we
I
should
will go with my
advocate.
expert, Dr. Deepa, ma'am. One take-home point, and I think we are done for today.
As everybody discussed, I would agree with that, like, non-judgmental, and they have to open up, and history, part of history, you have to ask how's your sexual life. And I think this generation, everybody, so much of awareness is there. They just walk in and they ask for the procedure. So that's how it's come to. So I think, like, we also should give them all the options. And I usually say all three is important: sexual health, mental health, and physical health. All three are equally important.
Okay, ma'am. And Revati ma'am has always been
Yeah.
together. So, madam, you
Yeah,
want to give some comment?
yeah, yeah.
Closing
One
comment.
one take home point is that all has been already mentioned. See, the practitioners are actually like a family doctor to the woman. So they should be well trained as to how to approach the sexual health problems of a woman. And the training must be given.
Yes, ma'am. So, thank
And
you.
of course, this is the delicate, difficult topic has been dealt with very beautifully by Priya and all the panelists. Congratulations.
Thank you, ma'am.
Thank
Thank
you.
you. That was kind of you. So,
And on behalf of all the panelists, I wanted to congratulate and thank Priya for
thank you, ma'am. I would like to
involving us.
thank
And
TNFOG Marathon CME, our President, Madam, Dr. Vidya Madam, Secretary Sambat Madam, and all the TNFOG Pioneer Madam, including Dr. Revati Ma'am is with us, and Dr. Deepa Ma'am. Thank you for joining us for the panel as well. Very much, ma'am. Thank you. And over to you, Gayatri.
Thank you
we're
very
looking forward to listening to Dr. Priya tomorrow also in our CMS and cosmetic gynecology combined CME.
Yes, I take this opportunity to invite all of you who's in Chennai. Tomorrow we are having the redefining menopause care, the role of cosmetic and functional gynecology. It's Savera, so please do come.
Nice. Bye.
Thank you so much. A very difficult, sensitive, and yes, which is also not covered in great detail in our curriculum. It has been dealt with it's been very, very talking. Everything has been so comfortable. I think the same way, if we take it to our parents, to our patients, it should be really beneficial to the masses. Thank you so much, panelists and Dr. Priya for the wonderful panel. For an official vote of thanks, I really thank our chief guest, Dr. Sesh Chai and Dr. Megha Krishnakumari for their time and for blessing the program. My special thanks to the judges who always been with us, the Yuva speakers for their wonderful timed performance, Dr. Deepa for the complete insight about a very recently advancing topic, and the panelists and the moderator, Dr. Priya, for their wonderful panel. Thanks to Vidya Madam and Dr. Sampath Kumari for taking this and doing this marathon for such a long period of time, and the Shield for their official platform. I also would like to thank God for being with all of us and taking this marathon throughout for all of us. Thank you, everyone. Thank you, delegates, for logging in large numbers. This is the motivation for us to conduct all these CMEs so that we at the comfort of our home are able to benefit so much. Thank you. Thank you, ma'am.
How many delegates do we have?
Now many have left, madam. Initially, I think we saw some 50 numbers. Then it came to some 40, 30 like that. It was wavering. And now I think most of them have gone because we were saying thank you for quite some time. So they've left. But I saw initially in between there were a lot of people there.